So the question that many of us in the field have been interested in answering is how can we improve symptoms, because we know symptom burden is incredibly high in this patient population. How can we enhance communication and decision-making to ensure that we're providing care that's in line with patients' goals and preferences while patients are receiving cancer therapy? And the while patients are receiving cancer therapy is a really important part of this slide, because those of you who are familiar with hospice care might look at this slide and say, well, geez, that's what hospice does. And that is what hospice does, but the difficulty is, and it's a good news story, is the last decade there's been tons and tons of new chemotherapies and targeted therapies for patients with lung cancer. Patients are receiving more treatments and they're living longer, and for the most part, hospice isn't an option when patients are receiving cancer therapy. So the research is basically about this sort of chiasm. When patients aren't receiving hospice because they're still receiving cancer therapy, but they have all of these challenges and struggles of living with a cancer like lung cancer, can palliative care sort of bridge that gap and improve the quality of life and experience for lung cancer patients and their families? So a little break here for those of you who aren't familiar with palliative care to just describe that to you. Palliative care is specialized medical care for patients with serious illness that focuses on providing relief from symptoms such as pain and the stress of a serious illness, regardless of what the diagnosis is. A big difference between palliative care training and traditional training that, for example, oncologists do, is that palliative care providers focus on not just the patient, but also their family. Palliative care is provided by doctors, nurses, and other specialists who work with the patient's other doctors, such as their oncologists, to provide an extra layer of support. And it's very important to remember that palliative care is appropriate at any stage in a serious illness, even if the goal of treatment is to cure the patient if they're having symptoms or distress that can't be managed. It's a very common misconception that palliative care and hospice care are the same, and that is not true. Hospice provides palliative care, but exclusively for patients who are near the end of life. And in general, patients on hospice care are asked to forgo curative or life-prolonging therapies. So again, the big advantage of palliative care is that it can be provided regardless of whether someone's receiving treatment, whether they're eligible for curative therapy, and regardless of their life expectancy. Despite these important differences, traditionally, even up to 5 or 6 years ago, palliative care was only administered or suggested at the end of patient's life. So the traditional model of palliative care was the one on the top of this slide. The patients would receive their life-prolonging or curative therapy, and only when those therapies were exhausted would the doctor recommend palliative care. The more ideal mix is at the bottom of that slide, that patients can be getting their cancer-directed therapy, their chemotherapy, their radiation, and the surgery, but palliative care is always a focus of their care to make sure patients and families are getting the best care that they can, but the focus of palliative care may increase as they become more ill from their cancer. One of the first studies to look at the role of palliative care was a project called Project Enable, which enrolled over 300 patients with a new cancer diagnosis, and patients were randomized or coin-flipped into their usual oncology care or a telephone-based nursing intervention that had a palliative care focus. So basically, the goal of the project was to encourage patients to seek out additional care when needed, to be self-managing their pain, and empower them to reach out to their caregivers when their needs were not being met. The study was delivered to a rural population, so the entire study was administered over the telephone by nurses who had palliative care training. And the data from this study is really fascinating. So there are some slides at the top going from left to right that look at quality of life, symptoms, and depression. And basically all 3 of those elements were improved with this intervention. I think the biggest take-home point of this study is how easy it is to make patients with cancer feel better. All they did was call them on the phone once a week for a couple of months. And that improved their quality of life, improved their symptoms, and improved their mood. This tells us that patients are really suffering, they're not getting all their care needs met, and even just calling them on the phone can be very helpful for making them feel better. An unexpected finding of this study was that patients who were receiving this intervention seemed to live a little bit longer. This is what we call a survival curve, and it can be a little tricky to look at, but if you see that thicker, darker line, that's people getting the intervention. And if you look along the bottom of the slide, that's time. So at each time point, it seemed like patients who were receiving this intervention were more likely to survive.